everyone, and thank you for joining us today for the International Standards Organisation TC 314 Ageing Society's third annual webinar. My name is Anne Livingston, and I'm the convener of ICTC 314 Ageing Society's Communication Technical Group. I will be moderating today's webinar, which is focusing on ensuring inclusive and non-discriminating approaches in ageing societies. By way of background, TC 314 was established by ISO in December 2017. This recognises, as a result of increased life expectancy, many societies are ageing in many countries. In addition, developing countries and regions with rapid economic growth will be subject to increases in their ageing population over the next few decades. Whilst increasing ageing of society presents challenges, such as increased pressure on health and social services, there are likely to be opportunities that allow people to effectively manage their long-term care and live a high quality of life independently. So the work of TC 314 is very important to look at the role that global standardisation will play in this agenda. Tonight's session is going to be presented by the esteemed Professor Malcolm Fisk. Professor Fisk will be talking on age and ageing, how data can divide and unite us. Professor Fisk is the Professor of Aging and the Lifecourse at the University of Central Lancashire in Northern England. He carries responsibility for coordinating the university's activities concerned with ageing actively and taking into account a range of issues regarding health equality and the configuration of support services. Many of you know Malcolm well. He has an extensive and internationally acknowledged track record for digital health, having published widely over 140 publications, including 5 books, and I believe the number of books is growing. Professor Fisk has spoken at over 200 presentations as a keynote speaker from Portugal to Taiwan and to Australia. It's my pleasure to welcome Professor Malcolm Fisk to tonight's presentation. Thank you, Malcolm. Welcome.
Thank you very much, Anne. Right, just as a very, very brief addition to the description that Anne made, and thank you very much for the flattering approach to my CV, Anne. There's some good stuff there, I think, but obviously there's an awful lot more to learn, and there's an awful lot more I think we both share a concern about the ageing population and how to be very, very positive about ageing and ensure that when we address life course issues that we look to people's quality of life rather than simply surviving into an older age. So Anne mentioned that my title is actually Aging and the Life Course. And this means obviously that I do take a long-term perspective on older age, and I guess the focus really kicks in about 50, but nevertheless there are quite a number of issues about people's lives and behaviours and so forth that really do require to be recognised as influencing older age, even when they're taking place in people's youth and young adulthood. So it does put a different perspective on things. Nevertheless, quite the highest proportion, of course, of services around health and care are aimed at older people. So they must clearly feature very much in our consideration. Right, first of all, I'm talking about data mainly, or I come onto data anyway, and just thinking about how the challenges and issues around data have changed, especially in the last 20 or so years since the internet and since we have much more complicated and much more powerful communications networks. And the world of data that I'm considering must consider, obviously, issues around health and health data, and the technologies and the networks that data is transported on. And this means, of course, there's a wide variety of different agencies, organizations that are involved in data gathering, sharing, and analysis. Now, in talking about health, by the way, I emphasize the fact that I'm not just concerned with health in its clinical sense. We are concerned with wider well-being, and that's really why I made that comment right at the outset about behaviors and so forth. It's about our lives as whole people, as fulfilled people, rather than just the fact that the bits and pieces of our body actually work reasonably well, or can be fixed if they become faulty. So it is very much about behaviors and lifestyles, and those behaviors and lifestyles are quite clearly important in our later lives as well. So there are some primary considerations about how we as people, not necessarily as patients, we're only occasionally patients, I hope, and mostly people, how we relate to the providers of health and related services, how we relate to the technologies that mediate between us and those providers. And we're all of us now familiar with all kinds of terms around e-health, telemedicine, telecare, telehealth, m-health, telepsychiatry, almost anything can be taken under that label, with the tele, of course, indicating the fact that services are accessed or provided remotely. And more of this is not just about how technologies are provided for us or used in ways to deliver or provide services in particular kinds of ways. They're also now the technologies that we use for ourselves to gather information, to interact with services and all the rest of it. So it does bring a wider variety of technologies and, of course, some additional choices for us as consumers, as users, as patients, as people. Now, I want to put things into context, and Anne just hinted at it in relation to further books to come. I am doing quite a lot of work about how we relate to different technologies and how that relationship does change. But there is a bit of a long history, which is worth just touching on, about our relationship with tools and machines and so forth. And I shall argue very, very strongly that machines, technologies, are not neutral. They must be seen in the context of how they are used. Some of them, of course, like this caveman I've got here, may be making a tool for domestic use. Perhaps that particular stone he's hacking out a hole in is to put in grain, which can be crushed for cooking or medicinal purposes. But on the other hand, there is a range of technologies that can kill and maim and so forth, the kind of weapons that are used in warfare. And it's interesting that in the work that I am doing at the moment, that my starting point, after exploring a whole range of philosophers and social theorists and what have you, my starting point is around the Second World War, because it seemed that there was a kind of awakening after the Second World War to the fact that, hold on a minute, these technologies are creating all kinds of awful situations, being used to kill and maim and destroy, and that we really must have a stronger hold on what technologies are and what they should be allowed to do and so forth in the post-war period. So that is my starting point, and I won't bore you with too much information about what is going on in my thinking and will be in the book in the fairly near future. But you can guess that part of it is about the nature of care and what care comprises and how we need to avoid it being too linked directly just to tasks as opposed to more meaningful forms of care. It relates to human rights, it relates to issues of product design and a whole host of other things around surveillance and control and things like this. But anyway, the starting point was the war, and the underlying point here is that technologies are not neutral. We really, really should be having a stronger grasp on what they do and how they are used. So with regard to that long history, pointing particularly to health-related technologies, we have got that changing context. We've got the advent of different kinds of technologies, and we have the whole nature of healthcare provision being less linked to one which is going to help us survive in sometimes the dangerous periods that took place because of industrial change or disease and things like this. Also alongside that, of course, was better sanitation, improved sanitation, better water and all the rest of it, better housing, people had greater wealth and so forth. So there was a lot of other changes going on at the same time. And clearly within the health field, within medicine, there was professionalization taking place, which increasingly cemented the idea of what the medic should do vis-a-vis us as people or patients in our lives. And the illustration here, and I hope I get this right, is a sphygmomanometer, a blood pressure machine, effectively, which is one of the early innovations developed by Samuel Siegfried Karl Ritter, an Austrian, in 1881. So some good old technology there that was used to measure certain things and still used today in different forms to measure our blood pressure. And we had Wilhelm Röntgen, the German who developed X-rays in 1895, a long, long time ago. And you can understand how what's the right word, amazing or shocking the invention of X-rays was, because of the fact that doctors, physicians could actually see inside the body, something they hadn't been able to do before. And I'm old enough to have been taken by my mother to a shoe shop in the late 1950s, I think, and to put my feet inside one of these X-ray type machines called, what was it now, fluoroscope. Which was able to see your feet in relation to the fitting of appropriate shoes that no doubt my mum purchased for me to go to school in. But yes, so X-rays, very revolutionary, but a kind of sign of lots of things that of course carried on from that time with regard to technological innovations. And the key point I want to make here is that the idea of measuring things and having technologies to help us in measurement was gaining ground through different kinds of innovations like the sphygmomanometer and the X-rays as well. And it meant that physicians became less dependent on sight, touch, smell, and so forth. They became men of science. It kind of anchored medicine in the world of science, I suppose, within the arts. And increasingly, they were using data as part of that science. Now, the fact of the matter is that older people, being as disproportionate users of healthcare services, are therefore disproportionately subject to the medical regimes that took place and subject to greater measurement than other people. And we had clearly throughout the last century greater centralization of medical care, in particular kind of service locations, particularly district general hospitals in the UK, echoed in other countries as well. The idea was that patients would go to those locations as opposed to having an outreach, if you like, to people in their communities. Public health diminished in importance because of things like clean water and housing were being addressed. And physician to patient relationships became defined in a particular way, with the power very much in the hand of the physicians. And they, of course, were supported by the paraphernalia of their professional bodies, whether for administration, whether for qualifications, and all the rest of it. So very much their role became cemented in a particular kind of way, which we are familiar with still today. Now we have various transformations taking place. I mentioned the turn of the century, the turn of the millennium, as an important time. And that, of course, coincides more or less with the advent of the internet. And the interesting thing here, and I'm just looking at the illustrations here, the book that's on the top right, A New Kind of Doctor, written by Julian Tudor Hart, is a book that I purchased many, many years ago. And interesting that on the front cover is the female doctor there, but there is no computer on the desk. You look now at any kind of picture of a doctor in his or her surgery, and you will find a computer on the desk. And I'm pleased to see the woman at the bottom here is not looking at the computer, but is looking at the patient. Anyway, the point is that computer, the internet, and communications networks came into play. And there were big initial benefits, there's no doubt about it, for administration and planning. GPs were better able to target their patients and to list them for vaccinations, for checkups, or whatever it happened to be. And there was, fairly soon after the advent of computers in doctors' surgeries, the transfer of data from primary care into secondary care as well, involving, of course, more and more older people, because they are the biggest users of services. So older people, I think, coming more and more into focus in the context of community health services. I should add, by the way, that there is an interesting facet of computers in doctors' surgeries, and that is the fact that even back in the 1970s and 80s, when this started to take place, there were big companies like Honeywell who were offering computers free and services free and their software free, in order, well, as part of a reciprocal arrangement where they received patient data for whatever purpose they wanted to use that for in the future. And that's something that obviously resonates a bit today with the way in which clearly there are big commercial companies who want to access and use people's data, health data most specifically. So many new service tools around telemedicine, telehealth, telecare, and the other teles. And I've just done a short list here to data around data collection through these various devices. All of us will be familiar by now with social alarms and telecare. I certainly am. I did a lot of work in that field over quite a considerable period. But naturally, or what we're more aware of, I guess, with regard to the changes, is the advent of more devices like wearable devices, Fitbits and so forth, mobile phones, voice assistants like Alexa and so on, the idea of companion robots, and also video consultations. Video consultations, of course, have come very much to the fore because of the COVID pandemic and the fact that more and more people have got used to the idea of being contacted by telephone or video by their GPs or by their consultants, and that's definitely going to have a prominent place in the way that we link to physicians in the future. So that's one aspect, obviously, of technological innovation that is going to reach more and more people. Not forgetting, of course, that there are some people who are not technology enabled. There are not spots as well where reception is poor and so forth, which need to be overcome. So we have to be careful in applying or using such devices in ways that may actually lead to greater marginalization for some people. And the companion robots I mentioned here at the bottom, which I find somewhat annoying, to be honest, because sometimes they do reflect rather ageist and patronizing views of older people in the way that they are deployed or offered or considered as having a particular role. But watch this space. I do believe Paro has some benefits to some people, providing comfort and so forth, perhaps especially for people with dementia. Pepper, I give less credit to. You see there quite clearly a display screen and so forth. And if you have a display screen, why do you need to have a robot to carry it around and then communicate with you with a smiley face? Anyway, sorry, that's me being a little bit cynical. Anyway, older people definitely in focus in this new context of different devices as part of the technological transformation. Oh, and the other point is, yes, that a lot of the technologies have in the past at least been just doing things for people or to people, for instance, for activities of daily living, and not enough of them have really considered enough or try to develop the empowerment potential, which can help to motivate, can help people enjoy their interaction online for a whole variety of different purposes and not just in relation to their health. Now, the problem with aging in the current health context is the obvious point, which I've made at least twice now, is that older people are the largest group of service users. And of course, there are many governments who are thinking, this is who offer public funding to support health services, feel this is a burden of cost that is going to increase. And indeed, the costs may increase. And I emphasize that word may, because of the growing number of older people, especially for those with multiple conditions. And this will lead to demand for more medical interventions, often using expensive technology. Now, but if we look on the right-hand side of this slide, I'm arguing that the costs might not increase if people can be persuaded, prompted, encouraged to live healthier lives and take on board greater health knowledge, which will enable them to self-manage, will delay the onset of certain conditions, and will help them certainly in relation to the management of long-term conditions, and can be helped by the use of data, which may be shared with health service providers or may simply be observed and followed and understood by the user, the person, the patient, in order to help manage their own lifestyles. For instance, in the context of diabetes is a classic case where there are many people who are self-managing perfectly well, thank you very much, without necessarily sharing data with a health practitioner. And so that's one thing, is about behaviors, it's about people and their management of their own health, which is part of the equation. And by the way, with regard to long-term conditions, of course, there are plenty of people with long-term conditions, myself included, who are still working and, generally speaking, not placing too much of a burden on the health services that are available to them. Greater emphasis on prevention and public health is part of the deal, really, there, to help people to improve their lifestyles, to take more exercise, maintain their strength, and also, not to put too fine a point on it, to address the social determinants of health. Now, clearly, if we're talking about more private sector provision of health services, a lot of their priorities will be around profit, and it begs the question as to where the money is going to come from in the future, if it's going to come from public sources in order to help address some of those social determinants that the private sector organizations may be less concerned with. And there's an issue also about more older people being in the workplace, which is fine, but therefore what role can be taken, what greater role can be taken by employers with regard to supporting the health of their workers. And back over to the left-hand side of this slide, clearly there is the fact that older people's data are increasing in usefulness or increasing in value for health, as well as for the marketing of goods. This is one reason why, of course, some of the commercial companies want personal data in the health context, because it does leave the way open to marketing other services, whether it might be leisure services, whether it might be types of housing, whether it might be particular kinds of therapies, all sorts of things that can be marketed to a wide range of people that might be labeled under the title of the silver economy. And of course, the data possibilities for gathering data through different sensors is increasing all the time. So it may well be that the possibilities are quite frequently exploited or taken, if you like, with regard to the human genome, the bacteria in your gut, all sorts of other things can be monitored or will be able to be monitored fairly easily at low cost in the next few years. And the Health Foundation, this is a UK foundation, they reported only just a month or two ago, and it's an important point that the new technologies and healthcare innovations raise the possibility that some major illnesses could become more minor. So the prospect of our longevity, but with managed health conditions, potentially can increase in that context. And there's still the elusive idea of compressed morbidity, isn't there, where you live as long as possible, healthier life and die fairly quickly. Well, we haven't quite got there yet, but nevertheless, there may be some things happening that take us down that particular road. And there is the issue, of course, of the cost of all of this to the public purse. If people are in the workforce and they're paying their taxes and they're not taking pensions, then of course the healthcare services that they might get later on in their lives is going to be more affordable. So I don't think the key point I'm making, I don't think necessarily the costs are going to increase, and that if we do look at policy initiatives and practice changing in a way that helps people more to support themselves, using data, of course, as appropriate, but a whole new philosophy, if you like, around health that takes us away from the old days of the last century. So recap, different kind of devices doing different kind of things. Yes, I think I kind of mentioned them all in passing, but back to my caveman here, just to make the point really that the tools that we use cannot be seen in isolation. And clearly when it comes to data and the gathering of data, or one of the purposes of some of the new devices or newer devices for gathering data, then of course we're into a somewhat new area there, which is more invasive and therefore potentially more problematic for us. So important points, yes, there is a greater intrusiveness of different devices that seek to harvest our data. Traditional technologies tend to do things and were generally speaking, if they collected data, were doing that for a very limited use in particular contexts. What makes the difference now is that the quantity and range of data that can be collected and the ability of the networks to share that data very, very widely, and which raises a lot of issues around the control of the data and data ownership, which we probably haven't got time to go in. And it's an agenda which, or it's an issue that's going to rumble on, I think, because clearly the commercial companies want to take ownership at the earliest possible point of our data, whereas we want to, of course, our data, especially if it relates to our personal health conditions, to be safeguarded perhaps a bit more strictly than the commercial organizations would like. Yeah, and then there's some issues about, well, there, I've kind of just made it, haven't I, about data collection, because I think that people on the whole are willing to share their data with trusted organizations, you know, scans, blood tests, and all the rest of it. But clearly are wary of more commercially oriented organizations who may breach the limits of intrusiveness, i.e. intrude on our privacy, and may damage, therefore, the relationships of trust between people and physicians. And I see this particularly with GPs at the moment, who have a dilemma about, you know, their obligations to their patients, and then the demands that they should be sharing their data for research or other kinds of purposes. So there is a tension between the natural profit motive of commercial organizations and the objectives associated with health and well-being, of course. Such organizations may profit from our data, not just health, but through the data's secondary use. I've mentioned about the older people's market, increasing numbers, growing needs as they age, some older people with wealth, others who are vulnerable to exploitation. And both, of course, have to be embraced in the regulatory frameworks that we set out to control the way that sensors and systems gather particular data. And let's just, as a quick aside, but it's quite an important one, let's not forget the market for goods and services amongst younger people. If people are, what's the word, shocked, repelled, or whatever by the idea of aging and growing old, they see it in a very, very negative light, then that actually increases the market for younger people who want to actually to stay young. And therefore, there's all kinds of goods around anti-wrinkle creams and you know, exercise bikes and you name it, that may be expanded as long as there's that fear factor about aging. And this is one of the big dangers, because we do live in a fairly ageist society. We have service frameworks, attitudes, and norms that reflect this, and this brings some. I don't want to put too rosy a glow on aging, by the way, because there are, for many people, different conditions, different vulnerabilities that must be confronted, must be dealt with, and hopefully managed, or where we will need help in managing them in our older age. Now, so the imperative for aging and older people, I think we must agree that there's a growing imperative to gather our data for better health treatments, and for those data to be used, for instance, through artificial intelligence in relation to our health individually and collectively. So there's a research obligation there as well. And it will improve quality of life for all. We're already seeing some of the very, very positive outcomes of early uses of artificial intelligence, and the greatest potential benefits, because we're the greatest users of health services, is for people who are aging or close to the end of life. Are we on track? Will such data divide us or unite us, is the key question. And a supplementary question asks, how might standards help shape the context for data collection, harvesting, and use with aging and older people in mind? So if we want data to unite us, this means recognizing a number of threats. Quite a few of them do relate to ageism in our ageist society. And we would make a grave mistake, I think, if we don't recognize the human rights of older people as equal to everybody else. And this means that ageist service approaches need to be avoided, because those ageist service approaches might support continuing use of gero labels I put here for many of our specialisms, whether it's gerontology, geriatrics, or whatever. Also, we've got chronological markets of retirement age, which can be seen as ageist, because of people generally seeing decay and decline after that particular age. Ageist service approaches might allow others to take our data with insufficient regard to our consent and our choices about how our data can be used. And they could sustain people's ageist assumptions about older people being technology averse, whereas the evidence is clearly that is not the case, though quite clearly a lot of older people didn't work in the kind of context that I and others work now, where computers are part of everyday fare and data is part of everyday work. We've had ageist service approaches that have compartmentalized older people into special forms of housing, where the real issue is the design, not the bringing older people together. And we certainly don't want to have an ageist service approach which infantilizes or patronizes older people through the design of technologies, such as those relating to companion robots. More threats come from the changing nature of technologies. I've made the point that they are never neutral. They are sometimes intrusive and can be excessively so, so that we might legitimately start to ask, if we're not asking it already, as our data is harvested, who owns our bodies? There are threats of 24/7 surveillance and the ongoing, seemingly endless predisposition of some policymakers and providers towards technologies to gather those data. The most brutal and intrusive exposition of surveillance being the medical gaze that can be imagined in that kind of context. The notion of the medical gaze is, of course, an idea which was initiated, I think, originally by Michel Foucault and lives on today about the importance of surveillance, or certainly monitoring, in a way that enables data to be gathered in order for treatments to be provided. And also we've got the threat that just simply arises from the adherence to ageist norms, by which some commercial organizations reinforced ageist service approaches. Yeah, and clearly we must recognize there's more threats around the already disadvantaged position of many older people, not just because of health needs, but because of societal factors, especially for women, being as they live longer and who have perhaps had a shorter period of working life, lower incomes and all the rest of it. Biases in the data, this is a subject for a whole separate webinar or broadcast, but with regard to artificial intelligence and especially machine learning, where there's obviously quite a lot of manipulation that will take place with those data, means that various biases that relate to the data that is collected can be reinforced and then fed back in decisions about treatments or prioritizing different particular groups and so forth. And yet, because we cannot fully understand, or very, very few people can understand the outcomes sometimes of AI analyses, especially through machine learning, there's a need for audit trails in order for us to know, or for anyone to know, how the decisions were made, how they were arrived at, and were they arrived at correctly. We do need, of course, to be aware of the motivation of some commercial organizations to exploit older people's data in the context of what they see are rich pickings. Now, I'm going to just go on and offer you two scenarios. One or two of you may have seen this already, but this is from the work of Madeleine Ackridge, a French social theorist, and she had this notion of scripts, and scripts are kind of relate to the approach taken by service providers. They could relate to a wide range of other things, but which underpin certain kinds of behaviors. In this case, I'm looking at scripts that might apply to certain commercial organizations, and they could come from two different directions. Here's the first one. This is ongoing a work of mine, by the way. This is, consider or put yourself in the shoes of a company that is manufacturing or developing a particular product for the healthcare field, in the telehealth field. Our company product is intended for telehealth services. We must make a profit, but we're also in the caring business. So what our product does must be suitable and acceptable to end users who may be vulnerable, uncertain, and anxious. We will have to reassure them and gain their trust. Our product must help them do this by making sure that its use fits with the user's sometimes changing needs and choices, and ensuring the control and security of their personal data. Now, an alternative approach for someone who is less concerned with people's well-being would be, The silver economy is huge and rapidly expanding, and many older people have big savings. This means rich pickings for us with our new product. We must make sure that the old folk want it. If they're vulnerable, uncertain, or anxious, we want them to stay that way so they're ready to buy. The icing on the cake is that we will be able to scrape their personal data, and we have a deal ready to sell their data to Microsoft, who can then further exploit the market through other products and services. Sorry, another bit to edit out. These scripts indicate that the extremes for different commercial bodies, but they're really out there, and quite clearly we would want to, through different regulatory frameworks, standards included, to nudge, more than nudge, push people towards the first script, the first scenario, if you like, whereby the profit-making imperative of commercial organization is balanced by one which is truly understanding of what health and well-being really is, and how that must be part of their offering. And the final question is, what will the world of standards do to change things? How far is the ISO TC314 able to respond through its working groups? What more can be done to get it right around data in the context of aging and older people? Thank you very much.
Thank you, Malcolm. That was a great presentation, very thought-provoking. I guess some of the questions that we've got in are related to the increasing digital divide. You've covered many of the issues in the digital world, but many are concerned. I think there's 4 or 5 questions around the increasing digital disadvantage of older people, particularly when governments are moving towards digital first policies. And we know many developed countries have that, and as well developing countries. Do you have any comment how we might stop that digital divide getting bigger and deeper?
I've probably got several comments I could make about that, coming at it from different directions. I mean, the first point is just to reiterate the fact that older people on the whole are not technology averse. If there's technologies that work for them, then they're ready to adopt them. So that's a good thing in the first place. Obviously, to adopt them means that they must have the networks in place, they must be able to afford them, and they must be offering or giving access to services that actually suit their particular needs. But nevertheless, that's a good starting point, is to recognize that older people, yes, are not on the whole technology averse. They may well go for technologies. Some may have a resistance to technologies, but don't forget that resistance both does relate to their working experience and so forth, but it also in many cases does relate to people's distrust of the organizations that may be providing or promoting the services online, or distrust, or they might be wary of the idea of phishing and I don't know, all kinds of things being marketed to them which they don't want. But nevertheless, I say there's still a positive thing there in the middle of it if we get the technologies right. So the second thing would be around the design of those technologies, and it comes back to those scripts in some respects. A company who wants to make loads of money can take 2 approaches, perhaps, especially if they're a big company with plenty of resources. They can say, well, we can try out all these different things. It'll only cost us, you know, $2.5 million or something, and if it doesn't work, we'll try something else, until they hit on something that's going to actually work, regardless of really whether it actually suits older people. As long as the market is big enough, they can pursue that, and they can always tweak it a bit if it's going to be suitable perhaps for an 85-year-old as well as a 25-year-old. So that's one approach. A second approach is, hey, well, look, we want to get this right, you know, so who shall we ask about older people? And so think, oh yes, we'll ask the clinicians. They deal a lot with older people, but of course clinicians deal with ill older people. They deal with older people who are seen as patients in the old mold of patients, not in any way particularly empowered. And so the company may then develop a product that fits with the clinician's view of what the technology should do, and therefore is going to be gathering data in a particular kind of way, without necessarily giving sufficient attention to potential consent and other things or choices that a user might want to exercise. Now, a third approach, of course, is one where you could actually involve older people. Heaven forbid, you can actually consult with the people that are going to use the products at the end of the day. But this, of course, it means that you might get something a little bit more meaningful, accepting that's not the perfect answer either, because older people are so variable. Of course they are. And they range from, if you like, 55 years to 105 years and a bit more. And of course, I've had all kinds of different kinds of life experience and choices and preferences and different life circumstances that is very difficult to take into account. But at least it's a better starting point than going to the clinicians or actually assuming that we're just going to try this out and see if it works. And if it works, that's fine. We'll put more money into it. Now then, so getting it right means getting the designs of the technologies right and making sure they are configured in ways that are going to be responsive to the needs of the, if I must use that word, market, I suppose, of older people. But the flexibility and configurability is important here as well, isn't it? Because if you've got someone with early stage dementia, and there's a technology that kind of works for them, it may be that gradually, as that condition worsens, you're actually wanting to monitor a bit more closely that person and their behaviors, if they might start to wander or whatever. So there's configurability as part of it. There's another issue around intrusiveness, around the design of the technologies. What you want in your living room or your kitchen may be very different from a clinical point of view, from your personal point of view. And then you've got, I don't know, let me think. Well, design of the technologies, the more awareness of the companies, therefore, is part of it. The way they design and develop and market the products is important. I suppose underpinning both the things I've said there is the fact that you need to shake people out of their ageist ways of thinking, and to actually appreciate the fact that you can actually see things in a very, very different way. It's human rights again. And maybe there's something that needs to be done to pick them up and hold them to account where they don't take these approaches, aside from waiting for the market to respond. And I suppose one of the biggest risks is that so many older people have internalized fairly negative self-views, and where they are less assertive, perhaps, in wanting to make those choices, or they have got no choice because, yes, the doctor says this, or the social worker says this, the occupational therapist has assessed me, so they must be right. And so there is some issues there around choices and what have you.
Thank you, Professor Fisk. You spotlighted AI, and you spotlighted the biases that AI might have towards older people. Broader than that, what do you see as the major opportunities, maybe one great opportunity and one great challenge that AI presents to aging societies?
AI is a huge opportunity to supplement the work of the clinicians that we value so much. Sorry, I mention one thing before I carry on answering that question, because very often there are policy documents that come out which talk about data-led approaches. And I say, hold on, we don't want approaches that are data-led. We want them to be data-informed. And that very way of talking about it is one that reflects, if you like, my view, and I think the right view, I hope, that actually people can use the data in the same way that the doctors did with X-ray machines or whatever devices they had in the old days, could actually use it to help them, with the patient, perhaps, make decisions about what the best caring options are. What we don't want is data-driven approaches which are don't involve, if you like, that element of consideration or thoughtfulness or subtlety even in relation to different conditions, different approaches, not just to conditions, by the way, but also to lifestyles and things like this that can affect people's well-being. Right, AI, hugely important. The biggest successes that we see at the moment are in AI being used to help diagnoses of things like breast cancer or skin lesions and things like this, where they have vast quantities of data that they're actually drawing on, very often historic data, which is fine, but where the AI is shown to be able to work more effectively than clinicians and radiographers and people like this. Now, actually, it's very, very good in terms of efficiency. Radiographers, of course, think, "Oh heavens, is my job going to be here in 6 months or 2 years down the line?" But nevertheless, there's all kinds of important advances there that are making diagnosis easier and therefore treatment easier and quicker and earlier than otherwise would be the case. So big tick in the box there. Where things are, where the hype is all wrong, is in thinking that means that AI can do almost everything. But if you're looking to looking at the health conditions of over 75-year-old Torres Straits Islanders or something, a sample or data that is very relevant to that particular group of people. You don't want them to be absorbed within some much bigger sample, which is not going to tell you anything about the Torres Straits Islanders at all. And also for particular conditions, you want to be able to focus in on particular groups. So the most important thing is not the size of the sample. The most important thing is understanding the data and understanding its relevance. And sometimes you'll see people talk about the representativeness of the data. Well, that's a very difficult thing to achieve, given the objectives that we might have around AI. But the relevance of the data is also crucially important as well. So then you can always argue the case, well, oh yes, it's made this particular decision, or it's pointed to this kind of diagnosis, or it's pointed to this kind of treatment. But yes, well, hang on, that's a bit unusual. Oh, but you can actually then argue the case for why that might be, or maybe the sample was biased. Maybe you didn't have enough women in the sample, and maybe you've got to go back again and revise that and rethink that. But nevertheless, it's the understand. What we don't want to do is escape from our responsibility to understand the data, understand how decisions are made, understand therefore what the benefits can be of AI, and leave it to something which is a data-led approach, based sometimes, very often maybe, on dodgy data, incomplete data.
Thank you. Professor Fisk, that's probably all the question time we've got available today. I've got many more questions, and I'll seek some time to pass those questions on to you. But on behalf of the various people involved in ISO TC 314 Aging Societies, I'd like to thank you for your time today. Thank you for your insights, always brilliant and always well considered. Thank you for the work that you do in this area and the continual advocacy you do for older people. Thank you, Professor Fisk.
Okay, thank you, Anne. It's been a pleasure. And good luck with the ongoing work with the working group for the ISO.
Thank you. Thank you.